Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. Like so many parts of life during the pandemic, medical education has had to adjust to restrictions on travel and in-person meetings and classes. How has Mayo Clinic adjusted? Joining us today is Mayo Clinic Orthopedic Residency Program Director, Dr. Jonathan Barlow. Thanks for joining us today, Dr. Barlow.
Happy to be here.
So Dr. Barlow, just before the pandemic occurred, can you give people a sense of how medical education is regarding, for example, residents in delivery of care at Mayo Clinic?
Ultimately, we run at Mayo Clinic, there's a few models of medical education. I think at Mayo Clinic, we obviously prioritize that the needs of the patient come first, but we also are a three-shield institution where we focus on education, research, and patient care. So we have used a mentorship model to meld those areas together, and we essentially do one-on-one educational model for the most part. So essentially what happens, medical students graduate, they come into our residency program. It's a 5-year program. Each quarter they're assigned to a faculty that they shadow and work with. They participate in clinic, they participate in the operating room with what we call graduated independence. So they're supervised, but doing increasing amounts of the case as dictated. And through that process, they can sequentially learn more and more. The vast majority of our residents end up doing a 1-year fellowship afterwards, which many people have heard about, fellowship training. So that's one additional year to focus on something. You're a hand surgeon, I'm a shoulder and elbow surgeon. So there's a bunch of different fellowships that they do, but that's sort of the educational model over 5 or potentially 6 years for each of our residents.
So as you said, a lot of it is like an apprenticeship model with daily education. And when March came around in the pandemic, what happened in terms of education for our residents?
Yeah, it was obviously a big deal, just as it was for all industries. So we really had to look at it from a few different vantage points. Most importantly, we wanted to continue to ensure that our patients were taken care of. A very close second was our employees or our residents as patients and making sure that they were safe and well taken care of. But we also, residency is 5 years. If we have a long period of a lack of education, it could potentially really prolong their educational process or diminish their educational process. So that was sort of how we prioritized our goals. Essentially, at first, all of the surgical practice was shut down in terms of elective surgical procedures. We went to what we call a platoon system, which means that residents came into the hospital as a group because we really didn't know how this was all going to play out in March, April, May. So each group would come in together under the idea that, heaven forbid, if residents got exposed, that then they could be quarantined together and we could limit cross coverage or cross contamination in that way. And that was how we covered the trauma practice. As the practice ramped back up, we were able to go back to a normal mentorship model, but that probably took 6 weeks to 8 weeks until we realized that the situation with COVID had stabilized and our residents would be healthy throughout that period. The final aspect, which was very important to us, is how do we continue to educate these young residents so that they can be effective surgeons? And what we really ended up doing there is we transitioned to a mostly virtual education system. So that process was brand new for all of us. I think in the world of Zoom or other online technology has really become on the front of each of our minds as we've transitioned through this. And a lot of people haven't transitioned back to real on-site work. And it was similar to us. We went to a Zoom curriculum and we were doing Zoom lectures with our residents. We were doing a lot of interactive things over Zoom because we thought it was important to continue to maintain those interpersonal relationships rather than just saying, why don't you go read the books or watch videos for the next 6 weeks. So we flipped almost overnight to an entirely virtual curriculum. And interestingly, I think as we come out of that curriculum, we realize there's a lot of that we can continue to use. One of the really nice things about Mayo Clinic orthopedic surgery is that we can educate people around the world over time, but that oftentimes requires travel on the part of the consultants or the surgeons here. And what we found is we can be connected even if we're traveling internationally or traveling nationally, and we can continue that educational process through Zoom and other media. And I think that's going to really stay as a part after COVID is over.
Yeah, you make a good point there about touching many people, not just locally, but also internationally and nationally. Can you tell us, how was this received by the residents? What has the feedback been?
Obviously, everybody was anxious about it. They were worried about their safety. They were worried about the safety of their patients. They were worried about their education. And nobody knows the duration of this epidemic. And we still don't really know the end date of the epidemic. They really engaged well with the Zoom conferences. I think a lot of them felt like it was almost accelerated some of their training because it was very in-depth and personal and interactive for especially some of the junior residents who were kind of getting up to speed. And I think they really felt both safe, but they felt like their educational process was able to continue. And it's a different side. Obviously, in surgical education, we focus so much of our time on the surgical procedures and steps, and then we assume, or a lot of the didactic learning happens on the side. So it obviously became much more didactic learning and less surgical learning for a period of time, but then they can carry that back to the surgical practice. And we've gone back to essentially now full speed surgical practice. So they're able to use some of those didactic things that they learned through COVID.
Yeah, as you said, thanks to the hard work of many people, Mayo Clinic has done this very safely, not only for patients, but also for the staff. Now, one of the aspects of residency education is before they're residents, they're medical students. And medical students frequently come to Mayo Clinic and they shadow and they watch us and what we're doing in the clinic and in the operating room. How did the pandemic affect their exposure to orthopedic surgery?
Yeah, that's a great question. So in terms of, we have surgical consultants, then we have fellows who are graduates of the residency program, then we have residents, and then everybody who's a resident has done 4 years of medical school. So as a medical student, you learn the breadth of medical care, internal medicine, family medicine, OB-GYN, all kinds of different areas. And then as you become a third and fourth year medical student, this process is interesting, but it's also anxiety producing for our medical students. They start to decide what they want to become. And then they go through a process which is called the match, and that matches them up with their residency program. So medical students need extensive exposure during that time, both to make decisions, but also to learn about the process. The medical student process has been probably the most profoundly disrupted of any of the other processes, because when we talk about essential workforce, they're one of the least essential workforce. And I don't mean that in an essential way, but they're very much there in an observing and educational role. With COVID, essentially they got pulled back into doing mostly virtual curriculum and virtual opportunities. They continued through our Mayo Medical School to get online and virtual curriculum. They have slowly started to be able to come back as safe into the clinical practice some. But for instance, one of the most important aspects of their medical school training is doing what are called audition rotations. So medical students, if they're interested in orthopedic surgery, can come and visit and do a rotation at institutions of their choice. And this year that process was halted essentially across the board. So people tried to do some virtual rotations and things like that. But that process has been heavily disrupted. The next step, which has also been disrupted, is the match process. So after they do those rotations, then they interview at each of the locations that they want. So believe it or not, up until just a few months before they graduate, they don't even know that they're going to be able to become orthopedic surgeons unless they match into an orthopedic surgery process. So as you can imagine, this is very anxiety producing, and but it's an important part of our process in order to make sure we have people matched into areas that they will succeed and also where they'll be effective in taking care of patients. All of the interview process this year for orthopedic surgery, and I think for all the other specialties as well, has gone to virtual. So those are going to be all Zoom or other Skype or other mediums. All of those are going to be meeting that way. So all of these touch points where we normally are interacting in an independent or interpersonal way have been disrupted by COVID, and it's in the best interest of the safety of the patients, but also in the safety of the medical students. So it's been a transformative year, and I took over as residency program director this summer. So it's been rapid escalation of my knowledge and understanding of the processes and how this works. But I think it's a great time to do it, and we have to keep making great doctors. We have to keep training medical students. We have to keep taking great care of patients. So it's fun to be a part of it.
Well, I can speak as one of your colleagues and partners. This certainly has been a baptism of fire, and you've done an amazing job. But one thing I wanted to ask you about is obviously when you're selecting the orthopedic residents of tomorrow, you want them not only to be the highest quality, but also to represent all spheres of life. How are you and Mayo Clinic working through this to make sure that we have a diverse workforce?
Obviously, this summer and going into this year has been on everyone's mind and on their hearts, really. This summer, we had just in our backyard here in Minnesota, we had the George Floyd tragedy, which really, I think, shook the underpinnings of a lot of our social interactions and how we interact with people. And it was just a really tragic thing. Mayo Clinic has been absolutely committed to diversity for a very long period of time, but has recommitted in the aftershocks of the George Floyd tragedy. And I think the Mayo Clinic orthopedic surgery program has done exactly the same. Our process really comes down to wanting the most highly qualified residents that we can possibly get, and the most highly qualified teams that we can possibly get. Inherent in that is a diverse workforce of people from different backgrounds, different colors, different races, different religions, different parts of the country, different socioeconomic backgrounds. And the data on this is compelling that when we work in teams like that, we do better. So we know that that's an important part. Orthopedic surgery is traditionally a white male specialty. So we have underrepresented minorities in terms of females, Black applicants, Latino and Latina applicants. And I think that is an area that we have been interested in for a long time. Our process is essentially to view each application holistically, looking at the applicant, but also at their background and potentially the systemic racism that has made things more challenging for them, some of the socioeconomic factors that have factored in, and looking at each one holistically. And it's our goal every year to have a diverse class and build this group of orthopedic surgeons who are, as we say Mayo trained, that are trained here, that are exceptional, and that are diverse. So we don't all look the same. We don't all act the same, but every one of us strives for that same level of expectation and excellence that our patients have come to expect. And when you come out and you're Mayo trained, I think all of our residents graduate that way. So it's been a really fun and interesting process to learn about it. It's obviously been humbling. You certainly feel exposed as you start to think about your background, each of our individual backgrounds and how we've been raised. But it's also been really fun to connect with. We have a number of Black residents who have connected with in depth and talked about their backgrounds and their exposure and what it was like through George Floyd and otherwise. We have a number of female residents, and we say, what has it felt like through this process? We have a lot of work to do, but I think we're moving the ball in the right direction. And I think if there's any silver lining, it's that this has been pushed to the forefront of everybody's mind, and we can be thoughtful and careful and strive toward more equality for all.
Well, that was very well said, and thank you for your work and obviously the many people that have gone into doing this. And just if you look at the orthopedic intern class now, you can see the diversity coming through. So thank you for that. Now, Dr. Barlow, in addition to being a master educator, you're a very accomplished shoulder and elbow surgeon. Can you tell us something that's new in your practice that you're doing today?
Yeah, that's my day job, right? Sanj, is I get to or have to do orthopedic surgery on the side. So I'm a shoulder and elbow specialist, which is interesting. And I'm actually a shoulder and elbow trauma specialist. So it's one of the unique aspects of Mayo Clinic where in most places they might have a general orthopedic surgeon, and in many places now they have trauma fellowship trained. And now I'm a shoulder and elbow traumatologist. So it's a fun world in which I can become very subspecialized, but also I think the world is expanding of orthopedic surgery, and you realize why we have to have subspecialists like this. In my world, I think the big revolutions have been, first of all, we have a number of additional options to take care of patients who have proximal humerus or shoulder fractures. Traditionally, patients were treated in a sling and followed, and we expected them all to, quote unquote, do well. And I think the data in the world continues to change in terms of evolving, because these are very typical in the elderly population, and expectations of our elderly population, expectations of a 60-year-old or a 70-year-old or an 80-year-old in 2020 is dramatically different than 50 years ago. It's important for us to continue to maintain independence for these patients and also pain control. So we use shoulder replacement much more for proximal humerus fracture. And I think that I would say the biggest thing about the shoulder and elbow, especially in trauma, that has changed is we just have more tools to deal with more problems. So fractures are the main one that I deal with. And then the other one that I think continues to come up is the idea of rotator cuff tears and rotator cuff issues. Traditionally, these were treated non-surgically, and in many cases we said, oh, it's too far gone, and you get injections and deal with it. And I think now we have options that are mostly arthroscopic or minimally invasive to get the vast majority of patients back to a very high level of function. And there's very few patients who we say in 2020, we don't have any good options to improve your shoulder function. In almost all cases, we have good options. Sometimes that's non-surgical, but when it's surgical, we've got implants and techniques that can really prolong the level of high function for a lot of our patients. And so it's an exciting field to be a part of. It's a field that continues to evolve over time, and we're continually learning new things. But I think being from a place like Mayo Clinic, where I can focus on these areas where patients have traditionally been underserved in terms of options that can improve their shoulder pain and function is exciting for me.
Our thanks to Mayo Clinic Orthopedic Residency Program Director, Dr. Jonathan Barlow. Thanks again for joining us today.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening, and be well.